Let's get the recording on. Okay, good evening, everyone, once again, and welcome to another episode of Mondays with Moshe. It's nice to see so many familiar faces back. Don't see any new faces, but there we have Harriet. Hey, Harriet. Thanks for joining us, Harriet Cabelli. I'm not sure if this is your first time on, but I know you've been wanting to join us, and it's good to see you. Good to see everybody returning and the numbers going up. Let us welcome our guest tonight, Lisa Ferentz from Baltimore?
Yeah, originally New York, Baltimore, Maryland now.
Baltimore, Maryland. Hey, Harriet. Good to see you. Okay. Well, Lisa's from Baltimore, and tonight's topic is on treating, I don't know if I'm allowed to say it, but borderline personality disorder. We'll find out whether that is a kosher word soon, I think sooner than later, but a very interesting approach to the complex trauma perspective on what some of us, or what the DSM classifies as borderline personality disorder. And this is something that I'm pretty sure many of us struggle with. Probably all therapists who treat individuals struggling with this form of complex trauma called borderline personality disorder have a very, very difficult time for one reason or another. Oftentimes not in the first session, sometimes it's a couple sessions down the road that it starts to become complex, probably when some of the transference begins to kick in and the client starts reenacting certain behaviors. Lisa, would you mind telling us a little bit about who you are, what your background is, how you somehow became interested and involved in this particular field of psychotherapy?
Sure.
And thanks for joining.
Oh, my pleasure. Thank you so much for having me. I appreciate it. I think it's wonderful what you're doing. So I've been in the field for about 38 years now. And I think I'm a little bit of an anomaly in that many really good therapists who specialize in treating trauma often have their own trauma history, their own trauma background. And so they bring that sort of passion and that life experience with them into the work that they do. I have a different story in that I grew up in a remarkably loving and safe and very wonderful family, Jewish family on Long Island in New York. And I learned at a very early age what it meant to be loved. And to be told on a daily basis that I was valued and that I was cherished. And as I began to grow, I realized that it was the fundamental reason why I was able to take healthy risks in my life. I was very involved in the theater for years and years. Had a wonderful time being on the stage, felt very confident, not in an egotistical way, actually in a very calm, centered, grounded kind of way. And I gravitated towards getting a master's in social work and becoming a therapist because frankly, I really wanted to pay it forward. I understand on such a visceral level what it means to have that sense of self-love and self-compassion, and again, a sort of quiet confidence. And I wanted to be able to help others achieve that same sort of inner peace, if you will, and contentment. And so that's really why I decided very, very early on in my career that I was going to start working with folks who came from trauma. Now, to be honest, it really made my head spin in a lot of ways. I was listening to stories of, family childhood experiences that I didn't know were possible for people to experience. And that was actually, I would say, somewhat vicariously traumatizing probably for me very early on in my career. I was learning.
So whatever you missed out, whatever you lost out in your childhood beatings, you got through your clients. Either way, life comes around, right?
Comes around, yeah. So learning about people who grew up in families with substance abuse and with parents who had undiagnosed, untreated depression and anxiety, and definitely working with people who experienced physical abuse, emotional abuse, and sexual abuse. And I honestly think that if I did not have that sense of groundedness, because I really grew up believing in the goodness of humanity and that people had the capacity to be loving and kind, I don't know if I could have navigated a lot of the really, really difficult stuff that I was, bearing witness to as a therapist early on in my career.
Well,
So
I
as I
think, I
began to,
think, but this is an anomaly in two ways. I mean, besides
yeah,
that you didn't have a history in complex trauma or in trauma,
yeah,
Alice Miller in her book, The Drama of the Gifted Child, makes
yeah.
this assertion that the only people who become therapists are crazy people like us who would want to sit and listen to people's problems all day, but people who are so grounded
Yeah.
and healthy, emotionally healthy, why would they want to do that?
Well, I'll tell you, I think that the gift of being grounded and healthy has made it possible for me to be as present as I am for my clients and to be an arbiter of hope for my clients. And that's something that I've experienced for years and years as I work with trauma. And frankly, it's something that is kind of coming back around with the feelings that are associated with COVID, and the kind of relentlessness and hopelessness. My belief is there's a lot of rekindling of earlier trauma for people as they navigate some of the dynamics related to COVID. So I think that I don't believe that you have to be a trauma survivor in order to be an effective trauma therapist. I think that there's a lot less countertransference that I have to navigate because I'm not hearing stories that are a reflection of my own life experience. And being able to have just that amount of spaciousness between the client's experience and my own, sort of positive, optimistic, hopeful beliefs, I think is a really valuable buffer in a way that enables me to be objective and effective with the folks that I work with, if that makes sense.
I mean,
Um,
again, it has the advantage that you won't over-identify with clients, but the
right.
disadvantage that it might be harder for you to identify with them potentially.
Well, here's the thing, and I really came to this very early on in my career, and I'm grateful that I did. I've always maintained that the best expert in the client is the
It's a
client,
client.
and that
So
I am the student. In many ways, they are the teachers. They are the teachers of my heart. I have learned truly everything that I bring to my work. I've learned really from my clients. I never ever pretend to fully know what they've experienced and how they feel. And I think it's really important as a trauma therapist to be honest and transparent about that. I don't think it's beneficial to say, I totally get it when I
understand, right?
don't totally get
Right,
it,
right.
you know? But what I am able to do is say, teach me what your experience has been and is. And so I think that when I bring that open-mindedness and that open-heartedness and that curiosity to each person who sits across from me, and I never take a cookie cutter approach to my work. Every client is unique, even though I've worked with hundreds of adult children of alcoholics and sadly hundreds of people who have been sexually abused or emotionally abused. I still hold to the belief that every client is unique and they have a unique story to tell. And as long as I am willing, and I am, to be open-minded and to learn from them, then I think that that's what enables me to ultimately be effective in my work.
Okay.
So working with trauma, as you probably know, means that you're also seeing a lot of self-destructive behavior because we're working with folks who are very dysregulated, who did not grow up with secure attachment. And I think that's hugely important. And so when they are dysregulated and they don't have healthy ways of navigating their emotional states or of coping, it makes sense to me that they're going to turn to things like substance abuse and eating disorders and cutting the body. And unfortunately, clients can be quite creative in the ways that they attempt to dissociate and self-soothe and be numb. So through that process, what happened was a lot of these clients who came to me with those kinds of issues had already been diagnosed as borderline by other therapists. And I'm going to travel back before I move forward and tell you that when I was a grad student, like 100 years ago, and I'm old enough that it was the first DSM, there were no Roman numerals after the DSM. It was the first one. And I was in my psychopathology class, and we would be processing what we were seeing in our field placements. And the name of the game was figure out which of the diagnoses your client has in the DSM, basically what's wrong with your client. That was my entire graduate school training, I'm sad to say. Figure out what's wrong with your client. That never spoke to me, that never resonated for me. And because I'm from New York, I did have enough chutzpah as a grad student at times to actually raise my hand and say to the professors, are we ever going to talk about what's right about these clients? Are we ever going to talk about their strengths, their resiliency? Like a lead balloon. That did not go over well at all. But I just knew, I knew even as a grad student that this idea of looking at our clients through this pathologizing lens is really not serving our clients' best interests. And I'm going to say that I think the diagnosis of borderline personality disorder is a death sentence in the mental health field. I think it actually puts a glass ceiling on the extent to which we as therapists believe that our clients can actually self-actualize and heal. So one of the things I'm proud to say, having been in private practice for 38 years, and as you mentioned, working with very complex and complicated trauma, I have never once given a client the diagnosis of borderline personality disorder, and I never will. And I'm going to demonstrate why. I'm going to ask listeners to just participate in this brief little role play. So let's say I call you up and I say, look, I know you're incredibly busy. We're all incredibly busy these days, but there's this client that I want to refer to because I really, really think that you can help him or you can help her. So please make time in your practice for her. She's borderline. Now, what is your immediate countertransferential reaction to she's borderline? Now, I've had the great privilege before COVID of actually training clinicians literally around the world. And I'm going to tell you that no matter where I go and no matter where I ask that question, the answer is always the same. That when therapists hear she's borderline or he's borderline, there is this immediate visceral reaction. And it includes everything like, this person's never going to get better. This person's going to be high maintenance. This person's going to drive me crazy. This person is never going to pay their bills. This person is going to be unbelievably demanding, right? The reaction is never, oh, this is somebody I could really help. And that's part of what I mean by the glass ceiling. Now, if we rewind the tape and I call you and I say, I know you're really busy, but I want to make a referral. There's somebody that I would love for you to see. I know you can help her. She's a trauma survivor. What's your reaction to that? And I can tell you again, across the board, the reaction is one of empathy. It's one of compassion. People often put their hand on their heart. I've seen this, when I give live trainings, therapists like literally put their hand on their heart and they kind of nod their head like, oh yeah, she's a trauma. Oh yeah, I'd be happy to help her. So the message here is that borderline is trauma survivor. And even more specifically than that, I want to make the case that borderline is attachment trauma in its core. That's what actually is what we're seeing when it comes into the room.
Now, before we proceed on that,
Sure.
in all fairness, Lisa, that same trauma survivor who we start treating, after 10 sessions, is the clinician still going, oh, or is the clinician going, oh? Like, when they pick up that they're really borderline?
But they're not really borderline. You see, it has everything to do with the lens.
But when the behaviors start coming out, where the clients start saying, you hate me because you don't text me back and you don't this and that, and and you don't know what you're doing and all that stuff.
Right.
Does the reframe of complex trauma really make a difference 10 sessions down the line?
I mean, it does, because there's two ways to potentially, it's a sort of crossroad moment. There's two ways to make sense out of the testing, the pushing of boundaries, the client getting angry, right? One way is, for me, the pathologizing road, and that is, oh, she's borderline. She's driving me crazy. But another way is to say, this is a reenactment of attachment trauma, and that it actually makes sense that this client is testing the boundaries, or it has no concept of what healthy, appropriate boundaries actually look like or feel like.
Amazing.
If I can hold that lens, that this makes sense to me, that this is the inevitable byproduct of attachment trauma, then a bunch of things happen that are really helpful. First and foremost, I don't take it personally. And that's really important. I think we can go down the rabbit hole if we start to personalize the stuff that's being reenacted in the therapeutic relationship. And so when a client, just to use your example, when a client says, you hate me, you never call me back, I feel so rejected by you, rather than engaging in a whole conversation, trying to defend myself or trying to convince the client, no, that's not true, which I think is a very common misstep. Where I go is, when else and with whom else have you felt this? Who else in your life has left you feeling rejected? Tell me about other times in your life where you didn't feel seen or heard or understood. So as long as I'm holding to the idea that what's showing up, it's not just transference, it's traumatic transference. And that's a term that people like Christine Courtois and others have coined. And I don't think it gets used enough, but I think it's a really important concept that there's this dynamic of traumatic transference that's showing up in the therapy room. And really what our clients are doing is they are giving us valuable information about their prior relationship experiences.
Yes, and they're also giving us opportunities to repair, which I want to talk to you about. We were discussing this before the show, and this is a very, very exciting opportunity for me to be able to, have you describe one of my favorite topics, which is how therapy really works, and how the reenactments and really works. But before that, I just want to make a quick announcement for those of you who have questions or comments. Please use the More button on the bottom right of your screen and raise your hand. And when you raise your hand, we will, at some point, I'll call on you and you'll be able to ask your question to Lisa. I don't like to take questions from the chat just because it's too difficult to monitor, but I can't resist taking Miriam's question, which is, do all people with borderline personality have attachment-based trauma? Is there an argument that maybe somebody's born with a predisposition or just with that kind of personality? There was always that argument, in the literature, whether it's trauma-based or it's perhaps genetic. What do you know about it?
I mean, my understanding of it, both from what I've read and certainly anecdotally, is that I absolutely do connect it to trauma. And again, more specifically, attachment trauma.
Yeah.
These are folks who did not get secure attachment in childhood. They did not get consistent, predictable, reliable, safe, secure attachment. They got one of the other three attachment patterns that people like John Bowlby and Mary Ainsworth conceptualized a long, long time ago. But I think those attachment patterns are completely relevant to now, like why reinvent the wheel? So these are folks who either got dismissive attachment, or they got ambivalent attachment, or they got disorganized attachment.
Okay.
And what I believe is that when you are not securely attached in the earliest, most formative stages in your life, the relationship template that you operate from is getting close equals getting hurt. And that's what these clients are bringing with them into the therapeutic relationship.
But is that even with not having had prior real abandonments, even with just having had, since we had been talking about, that I had asked you whether the attachment trauma or the attachment rupture had to have taken place during the infancy years of trust versus mistrust. You were making some kind of assertion. So would you say, Lisa, that in many or most of these cases where we see borderline personality tendencies or behaviors, that the attachment rupture happened during that phase or during the stage of trust versus mistrust?
I think that is absolutely critical. Yes. Because, as Erickson talked about, if you don't successfully resolve trust versus mistrust, it compromises your ability to successfully resolve all of the subsequent developmental milestones. Like, the foundation is resolving trust versus mistrust from
Okay,
zero
but
to
people who have ruptures in other stages of development will still have limitations in that stage of development. Okay.
Yes, but they'll also show up with more resiliency, because if you've got that foundational piece, I'm not in any way implying that you're not going to be significantly impacted, but by subsequent trauma.
So I have a question. There's I don't know if you ever heard of this. Somebody once showed me something really neat. It's called it's a scale called the measures of psychosocial, I'm going to say, I think it's called measures of psychosocial development, MPD. I found it, it's a scale, and I found it on eBay years ago. I bought a whole pack of like 100 of them. And what it does is it measures psychological development based on the stage, Erickson's stages of development.
Mhm.
Okay. Would you consider, have you ever, or would you consider taking a scale like that? All of your complex trauma or borderline personality clients or patients, having them fill this out, and it will show you very clearly where the psychological development was ruptured. Do you
Mhm.
think we could actually gather data on that, that most of your clients are going to come back with ruptures in the trust versus mistrust?
I do.
Can
And by
we
the
do
way,
that?
when,
Do you think we could do that?
oh boy, as if I don't have enough on my plate. But I think, yeah, I mean, I think that's an awesome thing to do. And I will tell you that when I train social workers, which I do all the time, I'm always inviting and encouraging them to look at a trauma timeline parallel to a developmental timeline. Where trauma occurs developmentally, I think is really important. People who have trauma, around identity versus role confusion, that's going to manifest somewhat differently than somebody who had trauma, chronic trauma at a very, very early age. So I do think it's important that we are simultaneously not just getting that history of the trauma timeline, but definitely coordinating it and correlating it to where was the client developmentally. Because yeah, the way they respond to it, the impact that it has, it's going to make a difference.
Okay, can we take a question? Faggy?
Hi, thank you, Lisa. This is a wonderful opportunity. I was wondering, I've noticed a person saying, yes, I felt it when I was little, like the example that you said before. Yes, and that is why I do this, and I cannot get out of this behavior, as if to use this as an excuse instead of taking responsibility.
Yeah, and I'm not in any way implying, Faggy, that we're not holding them accountable and that we want them to take responsibility, because for me, responsibility is synonymous with empowerment. So I definitely want to help my clients to move beyond learned helplessness, which I think is in part what you're describing.
Yeah, it is about empowerment, and it seems that this person wants to be in that childish mode, that everybody else around this person should be taking care of
Yeah.
them.
So what I would say,
almost getting a kick out of it. Okay, so everybody's taking care of me. This is so good. Okay,
yeah.
instead of.
Yeah. I think, though, that what it speaks to is that there is this unrequited need inside for coming from a much younger place and a much younger part of who they are.
Yes,
And
it is.
okay, and rather than the client continuing to be sort of codependent and reliant on other people to sort of meet those needs, the way that I work with it is helping the client to access their wisest, most compassionate part, and helping them to take that compassionate part and turn inward and bring the comfort and the reassurance to the younger wounded part.
Okay, so I just wanted to show you, this is a picture of the measures of psychosocial
Yeah, I
development.
have heard of
MPD
it.
scale.
Yeah.
Okay, it's a very, very fascinating thing. If I have a couple extras if somebody is nearby and wants to pick one up to try. But I would just be curious to see whether the information, you could actually corroborate the information with based on actual data to show that this so I think that would be fascinating. Okay.
Yeah, agreed.
Thank you, Faggy. We have another question before we move on. Henny, can you unmute?
Yes, hi. First of all, thank you, Lisa, for being here tonight.
Sure.
I'm gonna preface this by saying that I'm pretty new to the field in the social work journey, and I work in a school. I do school-based counseling, and I have like one or two clients on my caseload that present with these extreme behaviors that people often associate with like personality disorders or like borderline personality disorders. I never want to diagnose a kid with a label that carries such weight. But since they're, from your perspective, there's such an attachment piece.
Yes.
I believe that there's some with these clients also. From a therapist, is there a way to help nurture that so that they don't morph into adults that have this
Great question.
level of disorder, and
Yeah.
need?
Yes, it is a great question. Thank you, Henny. Listen, one of the most exciting things about being a trauma therapist in 2022 is what we now know in terms of trauma and the brain. And when I was in grad school, I was taught that the brain has a finite number of cells, and when one part doesn't work, no other part can compensate, and that basically we peak at 18 and then it's downhill from there. And thank goodness, because of people like Bessel van der Kolk, who's been able to study the brains of trauma survivors through functional MRIs and PET scans, what we now have is this beautiful word called neuroplasticity. And neuroplasticity means that our brains are malleable and they're capable of growth and change until the day we die. So although we're talking about the reality that these are kids who are not getting consistent, secure attachment, what we know now is that there is a profoundly mitigating factor, if you will, when they can experience secure attachment with other people in their lives. In other words, it doesn't have to be just their primary caretakers. So this is where I think the privilege of being a therapist is so powerful, because when we can commit to being fully present and predictable and consistent and as unconditional as possible, if we can move away from pathologizing what we're seeing and really recognize that these are inevitable creative coping strategies that very young children begin to evolve as a way to navigate and survive what they're living in and what they're living with. If we can provide that, when appropriate, psychoeducation, if we can normalize and depathologize what they're experiencing and give them that really reparative experience of secure attachment, it goes an incredibly long way towards mitigating what they might not be getting in their families of origin.
Mhm.
And this is why it's both powerful and such a privilege to
So,
be.
so in a sense, it's the same. It's pretty, if I'm understanding correctly, it's the same treatment as you would do with an adult with the same symptoms, except that you're nipping it in the bud much sooner.
Yes. Now, I think I'm a very big believer in psychoeducation, because when we can help our clients make sense out of their symptoms, their struggles, their experiences, we move them away from I'm crazy. So when we're working with kids, obviously we have to be able to present that psychoeducation in ways that are cognitively appropriate, given where they are developmentally. With adults, I find it a little bit easier because I can talk in a more, intellectual way with some of my clients. But yeah, it's relationship. It's our, again, unconditional and consistent presence.
Yeah, and I want to talk about this next. That's actually, I think, they're going to be the crux of tonight's conversation. But there is a interesting dichotomy in dealing with a child, in that they are still potentially experiencing the same trauma. So you have, on the one hand, the parents or whoever the primary caregiver inducing the trauma, and then you have the therapist who's trying to mitigate the trauma. What's that like? I mean,
that's really hard, is what that's like. And to be very frank with you, it's one of the reasons why I don't work with very young kids anymore, because I found it incredibly painful and difficult. And what starts to happen is the therapist succeeds in forging this very safe relationship, and the parent, who, by the way, first brings their kid in and says, "Fix my kid," the parent then
feels alienated.
Feels jealous and
sabotages.
That whole triangulation piece, it's very, very complicated. If we can plant seeds with kids, even just like basic things like saying, I want you to know that you are not responsible for what's happening in your family, that it's not your fault, and that there's nothing that you can do to change mommy or change daddy, because so many children go through their entire childhoods putting extraordinary amounts of energy and effort into trying to fix and change a dysfunctional parent. And so at the very least, letting kids know it's not their fault. And, they don't yet have the power to be able to do what they want to be able to do. I have a lot of memories of working with 12, 13, 14-year-olds where literally we would get a calendar and we would start marking off the dates to when they were going to be able to go off to college, because that's when they got set free. That's when
That's where they hold their hope.
That's it. That's
Wow.
it. So with kids, I think you have to be very future oriented, because you're right. Their present situation, it's often they genuinely are powerless and helpless. Now, having said that, I still train clinicians to work with young kids to help install an inner sense of safety. I think it's really important to assess how children talk to themselves about themselves. I think this is true with all clients. There's nothing more powerful than the way we talk to ourselves about ourselves. If we can reduce the inner criticism, the shaming, the judgment that a child has introjected from their abuser, and if we can encourage them to have an inner voice that is compassionate and loving, that's going to really be protective as they continue to navigate that dysfunctional family.
Amazing. Let's take another question, and then we're going to go on and move on to the discussion of treatment. Miriam Lobel, go ahead. Miriam? Change your mind? Let me just make sure she's unmuted.
Okay.
Okay, maybe her computer's not working. Okay. Okay, so let's move on. I want to talk to you because we had discussed this before the show, and this was very exciting for me. We're going to talk a little bit about the treatment of, you did a lot of sort of explaining and teaching about that the person who's exhibiting borderline features is really struggling with complex trauma. We didn't necessarily go into what some of those complex traumas are, but essentially what you're saying is that there's an attachment trauma, which means that this child was not provided with a secure attachment.
Yes.
And now, as we see in the symptoms, very often they are very insecure in the relationship. They're always terrified that they're being dropped or dumped or betrayed or stabbed in the back or hurt. And so pretty much what we know about them is that they're always going to punch back before you punch first in order to protect themselves from that pain of abandonment. That's so raw. Okay,
and
right?
To reclaim, yes, and to reclaim some semblance of sort of pseudo power and control.
Dignity, power. Okay. So I want to talk about the treatment now that we've discussed. So we're now in a place where we're not defensive anymore. We understand that the behaviors that are going to emanate from the client are really defenses and protectors for themselves, and we're sort of observers and astronomers on the journey, watching the journey unfold, kind of expecting a lot of these behaviors to happen and waiting for them to finally happen, and then we're going to go along with them. Okay. In treating these people, we're not treating symptoms, we're treating a person who's struggling with this insecure attachment or insecurity. We know that they are going to start experiencing us as objects. They're going to start having some transference, and then they may fake it in the beginning and be social and sociable and intelligent and nice until something starts to happen in which they begin to feel somewhat threatened.
Okay. I don't think they're faking, though. I don't think they're faking the
Well, I mean, I don't mean faking. They're not feeling threatened yet. So we're not going to see the part of them that gets reenacted in deeper relationships until we start to develop that connection a little deeper. But let's say, superficially, they'll be able to navigate the relationship well. Is that right?
Yeah.
Okay.
Yes, that's fair to say.
Now they start to feel that maybe you're not invested enough in them. You might not care enough about them. You might not be responsive enough, and that means they're just a burden on you. and the
Mhm.
things, the complaints and the insecurities start coming out. What is it that we're looking to accomplish? And how are we going to reenact this for that client so that they can start to heal?
Well, the one thing that you actually want to accomplish is to not turn it into a discussion about you and the client. And again, I want to reiterate that because I think that is one of the more common pitfalls. That as you feel that you're being attacked, or the client is accusing you of not caring enough, or the only reason you care about me is because I pay you, classic line that many of us have heard in our careers more than once, right? It's really important to not go down the rabbit hole of exerting energy trying to convince the client about how much you actually care about them. I do think that's a pitfall, because what's being reenacted, what's being articulated and communicated is not about us. Okay.
Well, that's
But
one reason. That's one reason. But I think more so, becoming defensive with the client is actually going to reinforce the idea that they can't
Sure.
be heard and they can't be
Sure.
understood and valued. So even
Sure.
more so, we want to not become defensive. We fall into the trap if we do that.
Yeah, exactly right. Exactly right. So we do want to have a very authentic curiosity and exploration of this experience that the client is beginning to share with us about not feeling seen, not feeling heard, not feeling understood. Kind of the ultimate wound, if you will. And again, I think a throwback to early childhood experience. So it's not like we don't want to cut this off on the past by simply saying, no, I really care about you. We don't want it to be, though, a conversation about, tell me more about how I don't care about you. So my recommendation here is that we begin to depersonalize this and get them to focus on, again, when else and with whom else have you had this very real experience of feeling rejected, of feeling abandoned, or the fear of being abandoned. So we definitely need to explore that, because that's going to bring you to the core wounds, right? And as we do that, the other thing that's critically important is you need to listen to the client's narrative about that experience. And what I mean by that is there shaming? Is there self-blame woven into that narrative? Can they talk about that narrative with self-compassion? And overwhelmingly, initially, the answer is no. No, there's a lot of shame about the fact that they experienced prior rejection, or that they didn't feel lovable, or that they felt invisible in their families of origin. And so there has to be, I think, woven into the work, sort of the cognitive reframing, if you will, but it's deeper than that. It's not just, I don't just work cognitively,
Right,
because
right.
it's actually
You
very
want to induce the cognitive reframe, not
right,
just tell them. Yeah.
You got it. But also, I want to connect it to the body. I do a tremendous amount of work on a somatic level, because that's really where trauma is stored and where it lives. It's not in the languaging part of the brain. It's visual, which is why clients go into flashback, and it's visceral on the body. And so it's not just tell me about when you felt invisible, but then really connecting it to, what do you notice you feel on your body as you talk about that experience of invisibility, or that
Okay.
experience of
Now let's talk about how this is healing. I really want the audience to get a good conceptualization as to how and why this reappears.
Because, as I just said, what Bessel van der Kolk has proven is that trauma is stored on the body.
Okay.
It's not stored in Broca's area, which is the languaging part of the brain. And so what Bessel was able to prove way back in 2004 is that talk therapy alone is not sufficient. It will not fully metabolize the trauma that clients are walking around with. We have to work with right brain-based expressive modalities. So the visual would be through art, using art therapeutically, working with sand tray. The visceral would be whatever paradigm you want to use: somatic experiencing, sensory motor psychotherapy, Gene Genlin's work with focusing. Doesn't have to be anything incredibly complicated, but Bessel has proven that it's not stored in the languaging part of the brain. So if we're just simply talking about it, that becomes, not only is that in part a superficial approach, but how many of us have had the experience of saying to the client, tell me what happened and then I can help you. And the client just sort of sits there and shrugs their shoulders and says, I know something happened with my grandfather, but I don't know. I don't have words for it, right? And we also used to label that borderline, by the way, that's a client who's being resistant or uncooperative or difficult. And fortunately, Bessel was able to show, no, it's not that they're being uncooperative or difficult. It's that we are accessing a part of the brain where trauma is not stored. So you have to go to the body.
Okay,
You
but
have to go
even then, my question really is, what are we reenacting? Okay, let's go back to what we were talking about before the show, and going into, let's say, Rogerian work.
Mhm.
What did Rogers do or show us that is going to be helpful in the context of the therapeutic relationship that's going to be healing?
I mean, I think the phrase unconditional positive regard, which is he's most, closely associated with,
Mhm.
he made clients feel seen, heard, understood, loved, cared about. There was no judgment. There was no judgment. He created a spaciousness for clients to be able to say whatever they needed to say, to feel whatever they needed to feel. And he did it, he I think normalized in a lot of ways that, and this is not his language, this is my language that I write about in my books, that it makes sense given where you've come from. It makes sense given what you've experienced in the past. And that is the shift from pathology to normalizing.
Okay.
We talked about DSM, and I just want to say that trauma survivors have their own DSM. It's way smaller, but they have their own DSM. And the way they've made sense out of everything that they struggle with is they are weird, damaged, bad, broken, dirty, abnormal, and crazy. That's their DSM. And so through unconditional positive regard, through psychoeducation, through our depathologizing their struggles, we are moving them away from this trauma-based DSM that says the reason why I struggle is because I'm damaged. I mean, how many people have therapists hear this every day from their clients, right? I'm
Dirty.
broken.
I'm dirty.
I'm dirty. Right.
That was today's, yeah. So I want to ask you something. In conceptualizing what you're describing as an attachment rupture in infancy and unconditional positive regard I want to put some things together here and hear your thoughts, okay?
Sure.
If the therapist can show unconditional positive regard, just even on a basic level in the way we understand it, and we'll try to take it a little deeper. Would you say that is in and of itself a reparation of a ruptured of an insecure or anxious, ambivalent, or whatever attachment? Because if my attachment wasn't strong and now my therapist comes and accepts me with all my stuff, whatever it might be, then I am having my first experience of a secure attachment. And the longer and stronger that solidifies into, the greater I heal, the more I heal. Would you say that that would be an accurate description of what you're trying to do?
Yes, and I'm going to add another critically important piece, and that is as they're having the experience, the ongoing, consistent, predictable, those are important, secure attachment experience with a therapist, the ultimate goal is for them to then introject and internalize that experience so that they can bring that to their wounded younger part. Okay. So that we are not the ultimate arbiters of this. We provide the modeling, we provide the experience, we provide the safe container, if you will. But the ultimate goal here is for the client to have unconditional positive regard for that wounded child inside, whom they have blamed, who they hold.
So do you mean by them actually verbally connecting it, or do you mean that that's what we're just hoping will happen? You mean by us verbally going back to that, history, finding it and sort of integrating what's happening here in this room to their old selves.
Yes, I mean, I do it visually. I do it viscerally. So it's a profound internal process. We're not just, I'm not just theoretically talking about it. It's literally inviting them to turn inward and first access that wounded younger part. And then how do you feel towards this part? And I'll be on a lot of Dick Schwartz, who I know you've interviewed, is a dear friend and mentor of mine for many, many years. And so I have definitely, been very, very inspired by internal family systems and a lot of the work that he does. And so that notion of, I don't call it self, I call it your wisest, most compassionate part, but same attributes. Taking your wisest, most compassionate part and turning inward towards your wounded younger part. And
I think self is just an acronym for that, by the way. Self, your wisest, most part. I think it was an acronym.
Well, he calls it self,
Yes,
course,
he
self
does.
versus part. So this is deep work.
Yes.
Now,
yes.
but I'm going to tell you that I think that how we establish the framework for this, and even giving the client like a beginning understanding of how can I talk to this wounded part with kindness, that's going to come from what we are modeling for the client in terms of the compassionate, kind ways that we are talking about their experiences.
Beautiful.
Right?
This is amazing.
Think of it as a two-step process that they have to first experience the secure attachment with us. We give them the tools, the modeling, and then we very transparently, I mean, this is not subtle, this is a very specific invitation that I'm constantly extending to my clients to now turn inward and see if you can bring that same compassion, your voice now, not my voice, your voice, to that wounded part inside. To me, that's where the ultimate healing happens.
Okay, interesting. I have another question for you. I want to continue this conversation, but Michal's hand is starting to hurt. It's been raised for so long.
Okay.
Go ahead, Michal.
Hi. First of all, thank you so much. I really like your emphasis on depathologizing, because
Good.
the therapy world has come a long way, but yeah, I appreciate that. Number two, you talk a lot about depersonalizing the client's reactions to the therapist. And my question is, like, what's the balance? Because sometimes it is like something, maybe it is, I don't know, I'm playing devil's advocate. Like maybe something
Right.
with my skills need to be improved, or maybe I did something that hurt the client so yeah,
Yeah.
I just wanted to know what the balance
Thank you
is.
for that. No, actually,
Yes.
thank you for that. I think that's really fair and that's really important. This is where we need to be very self-aware as therapists, because I don't mean to imply here that we never take missteps. We absolutely take missteps. We have nothing but good intentions, is never nefarious, I'd like to believe and hope. But yeah, there's no question that we can say something that rubs the client the wrong way, that we can inadvertently trigger a client, that we may not do adequate containment at the end of a session. We may not fully recognize just how dysregulated a client was during the session. And so this is where we have to always, I think, track and monitor our own process and do our own self-inventory. And listen, there have definitely been moments, many moments in my career where I'm clear, I said the wrong thing and I need to own that. And I think that's really important modeling also to bring into the therapeutic relationship, to apologize, to make amends, to make sure that I clearly articulate that it was never my intention to be hurtful. And if they got hurt and they need to process that with me, absolutely, absolutely.
And that
So
actually strengthens the relationship.
it does. It does. That's right. Because that is a dynamic, that's necessary in a healthy relationship, right? So I think, again, we have to have enough self-awareness to know when you're being accused of something, is it possible that you really have taken a misstep? And if so, by all means, own it. Like, don't be afraid to own it. If you though have really looked inside and you're clear, you know what, this is not about me. what she's accusing me of doing, we've talked 50 times, this is what her mother used to do over and over and over. And so once I'm clear about that, I am going to go down the road of when else and with whom else have you felt this or had this experience. But, and one way you can check it out, by the way, is to ask the client, tell me specifically what it was that I said or did, verbally, non-verbally, that left you feeling hurt, rejected, in other words, ask them for tangible data about that. And sometimes they give you that information and you're like, whoa, they're right. And sometimes they give you that information, and you're like, I'm real clear that that's, I didn't say that. I didn't do that. So yeah,
What
we do
they-
have to check it out.
What they say is data enough? Like sometimes it could be, I don't know. Some like that's enough data to say whether or not like it's me or if it's them.
Well, I'm always going, if I think that it is me, again, I'm always going to apologize. I'm always going to ask that follow-up question, when else and with whom else have you felt this? Because otherwise you really run the risk of kind of going down the rabbit hole. I mean, I provide a lot of consultation to trauma therapists, and I can tell you that they spend session after session sort of defending themselves as therapists and trying to convince the client that, no, I really care about you. And that's a waste of energy. That's a waste of energy.
And again, it's also invalidating to the client to try to defend yourself. But Michal, to your point, I want to make another point here, which is you have to also realize that I think with all clients, we say things that are either imperfect or that can be slighting or hurtful.
Sure.
Again, and when I say that can be, that means that it can be interpreted in different ways. They can be just based on the client's history and sensitivities, but not necessarily be bad or wrong. And one of the telltale signs of somebody who is somebody who's making a really big deal about something you did that's wrong is when they make a really big deal about it. You see, many of our clients who are more adaptive or more stable or secure in their attachment, if you do something that they're uncomfortable with, they'll say, Michal, could you not say that? Or I didn't like that. Or the thing you said yesterday, last session was a little hurtful. They'll process it and move on. But somebody whose attachment is really insecure is going to come at you making a really big federal case over some silly slip of the tongue, that you some word that you use that wasn't precise in describing something and make a really big deal. So that in itself is a telltale sign of their sensitivity being overblown and out of proportion. And when you look inside to introspect and determine what was going on, that should be a very big variable. Like, why was their reaction to something so seemingly trivial so overblown?
I love that. I think that's really, really insightful. The way that I sometimes will describe to my clients is sometimes something can happen in a present moment interaction, and the emotional response, let's say, is this big, right? But if underneath that there is a trauma history, then instead of the reaction being this big, the reaction is now this big, right? Because the present moment has also simultaneously rekindled prior unresolved hurt, or rejection. So I think you're absolutely right to suggest that when it's this really big emotional reaction that doesn't match
disproportionate,
doesn't match the current circumstance, then we have to be curious at least about the possibility that there is this concept of rekindling, that it's not just about the present moment and it's not just about us.
Right. Okay.
Yeah.
Thank you, Michal. Just for those of you who are asking questions in the chat box, it's really difficult to navigate them. I encourage you to please raise your hand using the raise your hand button in the More tab on the bottom right of the screen, and we'll be happy to take them, but preferably that way. Let's take a question from Faggy. Faggy, go ahead.
Yeah, first of all, I wanted to say thank you so much for reframing this, because I happen to have a relative who does fit like all the criteria for borderline, and I view her as a borderline client or a borderline relative, and viewing her as having a trauma history really helps view her in a very different way. So thank you for that.
Good for you.
Okay,
But
mission
I have a
accomplished, Lisa, mission accomplished.
Awesome.
It doesn't help
Peggy,
really
Peggy,
deal
will
with
you
her,
come
but
on-
it definitely helps reframe it.
I was gonna say, will you come on the road with me?
Sure.
Okay.
You're asking her. So, by the way, we have about 100 participants, so there's at least 100 people just tonight who are hopefully reframed, and then hopefully another 800 or 900 who will watch this afterwards. So
Listen,
you're reaching.
part of why the reframing is so important is because we're human. And so if we're going to look at these clients through that pathologizing lens, we're going to get angry. We're going to get frustrated, but like Faggy
Scared.
suggests,
I find myself feeling scared sometimes from
yeah,
borderline,
sure.
what they're going to bring
Sure.
next.
So if instead, you're really willing to hold this different lens, what it's going to evoke is a whole lot more compassion. And it's going to pretty dramatically dial down, the fear, the anger, the frustration that you feel. At least I have found that to be true over the years. And look, sometimes we have to do our own positive self-talk. We have to remind ourselves, take a breath. This is somebody who's got a lot of trauma. They're teaching me. That's how I always say it to myself. In this moment, they are teaching me about their trauma. And I think if you can hold it in that lens, then you stay open and curious and not angry.
Interesting. But I did have a question based on something that you said.
Sure.
You said that if the client would say that they feel like you're not giving them the attention and there's something that you did that was wrong, you would ask them like, whom and when did you experience something similar? I'm just thinking about this relative of mine, and the response I'm hearing her say is like, why are you changing the subject? Or this has nothing to do with that. I'm just wondering what you would say, like how you would navigate such a response.
Sure. And let me be clear that it's the initial, my initial response is not going to be when else and with whom else. I'm going to get there. My initial response is actually to be very validating and affirming. Tell me more about what you're feeling. I don't want to shut that down. I want to get more information about that. And by the way, because I want the focus to stay on them and not me, then I'm going to add things like, what are you noticing on your body as you talk about the emotion? Is there any visual imagery that comes to mind when you talk about what you're feeling right now? And all of those questions keep the focus on the client and the client's process, as opposed to putting the focus on you. Right. So when you sort of go down that road of being validating and affirming and inviting a deeper exploration of what they're feeling and really helping them to turn inward to notice, how is this landing on their body? How is this landing visually, cognitively, emotionally? Those are all sort of the doorways that I like to open with clients. How does it land somatically on your body? How does it land visually? How does it land emotionally? And what are the subsequent thoughts that it evokes? All of those questions, Faggy, get the spotlight off of you, and they put the spotlight on the client, which actually not only is that beneficial if we're talking about therapy, but it helps them to feel validated and seen and heard and understood. So that's going to all happen first before I'm going to, potentially open the door with, I'm curious, when else and with whom else have you ever felt this?
And you would say that most often clients are open to going to the past once you've done the validating and
yes, I will tell you that sometimes it's a question that kind of stops them in their tracks. It can be a little bit startling initially because perhaps they've not connected those dots in the past. And so as a clinician, you have to continually assess by asking, is it safe? Does it feel safe in this moment to go there? And if it doesn't, we'll revisit the question at a later time. So you also have to be assessing for the timing of can the client go there and connect those dots? When they're ready though, they become pretty fascinated and curious about, whoa, this is my dad, over and over and over again. Or God, yeah, this is my sister. My sister always left me feeling like that. And then we can, when they're willing and in their time, we can begin to unpack that. But I'm constantly sort of balancing the invitation to go to these places with inviting the client to continually assess, does it feel safe to go there right now? Because we don't have to go there right now. We can plant seeds.
Okay, great. Let's move to the next question because we have a whole bunch left. Bryna, just nice to meet you. I actually trained with Bryna's mother.
Cool.
Robin, I don't know, Robin Nyman. I don't know if those of you who knew her, she was a wonderful, wonderful person and clinician. And we trained in EMDR together. We were actually partners. So she was the only person who knows some of my deep and who knew some of my deep and dirty secrets. So go ahead. I have
Hi.
special hakaras to your mother.
Thank you. I just firstly wanted to thank you again for taking the time to be here for us. I guess my question is to piggyback off of what you were just saying, if there is a rupture that occurs, I guess, within a session, what would you recommend, I guess, a clinician do if a client like completely shuts down and no matter, you know, whatever approach or even like sitting with the silence, they really just, I guess, shut down or even don't show up the next few sessions? I guess what would be your approach in that situation when they're not willing to, you know, answer the questions that you suggest?
So it's a great question, actually. And I always think about like canceling an appointment, not showing up. I always, in my mind, reframe that as a form of pacing. And I'm very respectful of that. I let the client know, because it's also a test. And here's where we're back to the relational stuff. It's also a test, either sometimes consciously, often unconsciously on the part of the client. And the test is, are you now going to reject me because I was silent, or because I canceled an appointment, or because I wasn't cooperative, you know, in that session? And so I think it becomes an opportunity for the therapist to continue to articulate to the client that I am here. I am not going anywhere. And if you need to take a half a step back, if we need to end the session early today, if you need time to regroup, you know, whatever it is that you need, know that I'm not going anywhere, and that this does not in any way change the therapeutic relationship or my care for you, my concern for you. So kind of see it in a way as a test, because it often is. And the more you can communicate to the client that you're going to hang in there with them, even again, in times where they're not being verbal or particularly cooperative. See, that's part of how you're communicating unconditional positive regard. We have to be careful as trauma therapists that we never create a dynamic where the client feels that in order to retain the relationship, they have to be compliant with us, because that's a direct reenactment of victim perpetrator, right? So letting the client know whatever you need, like, I'm not going anywhere, can be very powerful for them to hear.
One of the things I find so hard is because we're investing so much energy in depersonalizing, in compassion, when these clients leave us, either because they become it becomes too much for them, too overwhelming, or because they become angry, I find myself hurting when they leave, because I end up investing so much personal work to be able to stay the course with them. And, you know, it is a lot of work on the therapist's end.
Yeah, I hear. But I want to give you a reframe to consider, Moshe, and that is, they didn't leave you. They left their process. They didn't leave you.
Okay, but I guess it does feel like a lack of acknowledgement on how much work I put in, you know, to work with them and say, he doesn't care. Yeah, my own stuff. Okay.
Yeah, that's it, honey, because you know what? We're not in this because I don't have, let me put it like this. I don't have the expectation that I'm going to get validation and acknowledgement from my clients. When it happens, yes, it's lovely. And it's very warming. But here again, see, when we are grounded, when we are leading from our wisest, most compassionate parts, when we know how to love ourselves, then our sense of self and even our efficacy and worth as clinicians is not going to be contingent on client outcomes. You've got like 96 people online tonight. If I ask by a show of hands, how many of you ever had a client who prematurely terminated? Every one of us is going to raise our hand. How
Right.
many of you had a client who relapsed?
But Lisa, okay, I guess I'm overstating it. I guess it's disappointing
Okay,
when
sure.
when the client leaves after you had invested that much
Yeah,
in working the relationship, so that the relationship works, so that you can help them repair themselves. Okay,
Yeah.
and then they leave in the middle. It's like, wait a minute, we're like in the process of you being able to be repaired, and you pull out in the middle. There's something
Yeah.
disappointing about that. Yeah.
No, I hear, and that's totally legit. You know, I always tell the students that I train, ultimately we're gardeners. I really mean this. Sometimes you have the great privilege of planting seeds, and then the client, you know, goes somewhere else. And then sometimes you get the privilege of working with a client where a prior therapist planted seeds and you get to water the seeds. And sometimes if you're really super lucky, you get to plant the seeds, water the seeds, and see the garden grow. But wherever you fall in that client's sort of journey, know that it's a privilege. Know that you have
Honor.
made
Right.
a valuable contribution.
Good.
Because you have.
Good point. Okay, next question from the mysterious Zoom user. Go ahead. Or identify yourself if you want. Okay, let's go to Shayna.
Thank you. Okay, so I actually have a comment. I just want to extend like a deep, deep gratitude to you, Lisa. This is the population that I find the most fulfillment and enjoyment working with. And in full disclosure, when I saw the email that what you were presenting on, I got very nervous because I was like, oh no, what's this gonna be? Especially just having the diagnosis there. I find it to be like very lonely work sometimes in this field because there's just so much misunderstanding, and just having you here, like I'm tearing up as I say this because it's just been so affirming and like hope giving to hear you talking about this with such a deep compassion and understanding. So thank you.
Thank you, sweetheart. You made my night. That's very kind.
I'm glad you stayed on past 10 o'clock, Lisa. You weren't going to.
That's right.
Shayna, thanks for keeping her going.
Always, I'm texting all my friends like you have to watch this one. I'm telling you.
Get them to
Thanks.
sign up for Mondays with Moshe, and we'll see you every week. We'll have Lisa back on, maybe earlier. Okay, Akiva, go ahead. Let's take from Akiva.
Oh, hi. Thank you for unmuting me. Thank you for, it's my first time here and I'm actually enjoying it. I appreciate it. Quick question. Anecdotally, would you say that there's any benefit of the gender of the therapist being of the one who, if the trauma is let's say coming from her father, would it be more beneficial if the, anecdotally, obviously every therapist will do their best, that a male therapist could maybe help repair that, or the other way around, the female therapist if it's from her older sister. Would you say that could ring true?
I think it is, and this is not a cop-out answer, I really believe this. I think it's case by case by case, because I've seen it played out both ways, Akiva. I've seen where, you know, having the same sex therapist as the parent who, you know, created the trauma or the rupture could be incredibly healing, or it could be so overwhelmingly triggering that, you know, the dust never clears and the client really struggles moving forward in the work. So I always ask the client to be very conscious of the gender dynamic and for them to sort of track and monitor, is this working for you? I don't think there's a hard and fast rule because I've seen it be beautifully reparative. And I've seen it, you know, drag the therapy on for years and years in an unproductive way. So it's truly case by case.
Yeah, I mean, I think, Akiva, I once read, I think I remember who the person who sent the source was. I don't remember the source, but I think Dr. Andrew Klafter, Nachum Klafter, discussed this, and he discussed that the research shows, again, I would have to go back to him and make sure, that there is really no difference between male and female therapists because they're becoming an object to the client. The transference, well, from what I remember, he said there really is no difference in who helps to repair relational trauma. I'm not 100% sure.
I think it is though the preference of the client. There are some clients who are adamant about wanting to see, a therapist of a specific gender. And there are some clients who'll tell you it totally doesn't matter, So again, I think it's case by case, and it's a matter of checking out with the client, is this working for you?
Okay, Solomon. Go ahead.
Yeah,
Solomon.
hi. First of all, thank you very much for this. This non-pathologizing reframing, is that also true for other personality disorders or only BPD?
If I had my way, it would be, for everything, because I just think ultimately we get a lot further, in dealing with some of the struggles that our clients have when we can help them make sense out of why they're struggling, and frankly, reframe a lot of their struggles as protective, as again, the inevitable
Defenses.
byproducts of trauma, defenses, if you want to use that word, right? So, I tried the best of my ability to, across the board, take this strengths-based depathologized approach. Ultimately, what I'm most interested in is what is right about the client, not what is wrong with them. And because I'm not a trauma survivor, the thing that I've always, all these years, been curious about is, how are you still standing? That question evokes a great exploration of resiliency.
Yeah.
And I sometimes ask clients straight out, how are you still standing?
Often it's the defenses themselves that keep the client standing. If always, it's the defenses themselves that the world is seeing as pathological that are actually the resilience and the coping mechanisms that kept them going. So we have to applaud. We actually have to appreciate and applaud the maladaptive or pathological behavior.
That's it. I call them the inevitable creative coping strategies. That's the term, that's the phrase that I use with my clients. These are your inevitable creative coping strategies. And are you interested in learning coping strategies that might not lead to an end game of shame or self-destruction? Because a lot of again, you're right, they're maladaptive and they often land the client in shame.
Beautiful. Okay, let's take the next question because hands keep going up. So Tippy, go ahead.
Hi, I'm sorry my video's not on. I can't put it on now, but this is very interesting. And before I get to my question, I just want to say, I've done that with clients also, where I say, this makes so much sense, knowing your history, of course you're like this. And it's so relieving for them.
Yes, it is. Good for you.
Really, so are you saying that if a client with BPD can get in touch with that caring self in them, and they can have that unconditional positive regard for themselves, they can remove their symptoms of BPD or the diagnosis of it?
I would say that they will transcend it. And the degree to which a client transcends it is going to vary from client to client. But I have certainly witnessed in my career clients who, got stamped borderline all over their chart by 10 different therapists. And by the time they did the healing work that they chose to do, they transcended those characteristics and those traits, and they were actually able to be in genuinely safe, loving, secure relationships. And I hold out that hope for every client. It does not mean that every client gets there. Healing operates on a continuum.
So you're sort of giving hope that it is quote unquote curable.
Yeah, I mean, again, I don't use the word curable because curable implies that it's a disease or a sickness to begin with. So what I do say is I think that they can let go of the protective strategies that they inevitably needed to use, and they can allow for a degree of vulnerability. Because if you think about it, vulnerability is sort of the antithesis of the defenses or the protective parts of who they are. So as they can allow for a greater degree of vulnerability, it means that they can let people in. It means that they can feel a depth of emotional intimacy and connection that the guardedness did not allow them to experience.
Lisa, I'm just thinking, I can't see how you'd be able to accomplish this, and correct me if I'm wrong, how you'd be able to accomplish this effectively in the context of a couple. Meaning this kind of work sounds so sacred in the attachment between the client and the therapist, that if we were to work with a couple and one of this, let's say one of the spouses is struggling with borderline personality, it would almost be impossible for them to not feel that the therapist is at some point aligning with the spouse, or like to not feel threatened enough in that relationship to ruin it. Would you say that makes sense? Or would you say you can do this even in the context of couples counseling?
I mean, I would really like to hold to the belief that you can do it in the context of couples counseling. I think it requires a partner who has the capacity to be genuinely a compassionate witness.
Okay.
I think that the partner has to have enough ego strength within themselves.
How common is that to someone who's married to someone like this? Okay.
Well, that's a different story.
Shiffy, go ahead, Shiffy. Always good to have you.
Hi, Lisa. So thank you so much. I think it's fabulous to think about borderline as complex trauma and how that really does open the possibility of treatment. And that's so comforting. I work at Olive Institute and run a program for interns that service incarcerated people and their family members. One of the interesting things is that we always talk about personality disorders as being a very prevalent and common thing that we treat, both in the incarcerated person and in their families. So we see a lot of generational trauma, generational personality disorders, people would say, but I call it generational trauma.
You got it.
Trauma. And it's really, it changes the way you approach it if you can just see it as, without pathologizing it. My question to you is, we do see an overlap of borderline and narcissistic personality disorder.
Yeah.
Some studies say there's like a 40% overlap. And in our population, it's pretty high. Mm-hmm. What is your experience with working with narcissistic personality disorder?
Yeah.
I know the big difference is the egosyntonic, ego-dystonic, which is what makes borderline so much more treatable than narcissistic personality disorder.
I agree with you on that, Shiffy. I actually agree with that. I think in some instances, what is presenting as narcissism is actually protective bravado. And that if you peel away the top layer of that narcissism, there's extraordinary insecurity.
Absolutely.
And a total lack of self-love and self-compassion. And so again, I think if you can focus on helping them really authentically connect with the part of themselves that frankly they hate and that they have a lot of shame about, if you can work to help to heal that, then some of the presentation of narcissism can dramatically subside. Having said that, I also have encountered, and if you know the work of Robert Hare and others, where there's an overlap between sociopathy and narcissism, there's a cohort of people who had that diagnosis of narcissism who don't do well in therapy. And in fact, it's interesting. They use the therapeutic relationship to learn how to mimic compassion and empathy. So they sort of parrot what the therapist is doing, and then they take that information to actually manipulate other people. So that's real. There's a cohort of people who have, I think,
it's almost like their wounds are deeper. Like,
yes, I think
their
that's
trauma, like if we want to talk about it in terms of trauma, their trauma is more complex or more, deeper, a much bigger trauma.
Yes, and there's also a neurological component with narcissism, because there's research, and forgive me because I can't quote the researchers, but when you say the word chair to a person who, like you or me, who doesn't have narcissism, a certain part of our brain lights up. When you say the name of one of our children, a completely different part of our brain lights up. With true narcissists who have sociopathic tendencies, when you say the word chair and you say the name of their child, the same objectifying part of their brain lights up. So these are folks who are lacking in empathy.
Empathy, right.
And who objectify relationships and human beings. So it is I think it's a more intractable.
So you're saying if they sit on their child, it's because they thought it was a chair.
There you go.
They do sit on their children, Moshe, unfortunately.
Yeah, just because they think it's our chair. Okay,
Yeah.
can we take one? Lisa, I know I promised you 10:15. Do you have time for one more?
Sure.
Malky, you're lucky. Go ahead.
Okay, I'm gonna go for it real quick. Thank you so much for taking my question. Okay, I have a client that has been stamped with the borderline personality disorder diagnosis for whatever the reason. She has a long history of many therapists that she has worked on this attachment, done a lot of IFS work with, etc. And what ends up happening towards their relationship as it progresses is she does a lot of over ideation and like boundary crossing, stalking, making phone calls to their houses, just messes up the things completely until they just can't work with her anymore. And then they drop her. And this goes on and on. She has many, like I'm the next online. So now she's my client. And I worked very, very hard to explain to her how important the boundaries are for her safety and for her progress. And still she's doing it. And she'll do this like, you're the most important person in my life. And this is the only place I feel safe and all of that. And I'm working very hard to keep her present and to, like you say, shine that light on the inner child, on herself, to give her that. But I'm wondering how to keep her in treatment and not lose her because of that. Over necessitating the attachment repair.
Well, what I want to say to you is that ultimately it is not your job or responsibility to keep her in treatment. So be clear about that, okay? Don't own that. That's not yours, honey. What I think one of the ways that I would attempt to work with it, I can't guarantee you it would work, but I would try, is I would say to her, I'm very curious to meet the part of you whose job it is to sabotage relationship by not respecting boundaries. I'd actually like to meet and talk with that part of you to learn why it feels necessary to protect you in that way, and to ask what that part imagines would happen if you did honor the boundaries and the relationship was sustainable, because there's fear about that. There's fear about, you know, if I play by the rules, you know, and get to stay in relationship with Malky, sooner or later, she's going to leave me. She's going to reject me. She's going to abandon me. So there's a part whose job it is to set this in motion with therapists so that the inevitable outcome is that she loses the relationship. But I'd be very transparent about wanting to work with that part. No judgment, no shaming, just total curiosity.
And I actually do that from the outset, by the way, when a client comes in and says, you're my 9th therapist. And so I will ask them within those few minutes, how long, you know, how long does it usually take before you leave your therapist? What usually triggers it, and how long do you think it will take in our relationship? And they laugh and say, no, this one's going to be different. I'm really invested this time. And I say, well, that might be that's how you feel now, but clearly there's something that occurs in the relationship. Where is it going to happen between the two of us? At what point will you feel hurt, or what are some of the causes that happened in the past? And then I'll actually ask them permission. Okay, again, it's similar to what you do, but my own version, I guess. I'll ask them permission, and I'll say, well, since we can fairly assume that this is going to happen within the, you know, at around the 3-month mark, you know, about 10 sessions or whatever it was that happened in the others, would it be okay for us to agree that when it happens, we try to change the response that went on between you and the other therapists? Would you be willing to come in for one more session after that and discuss what happened that made you feel so hurt? So this way, when it happens, we've preempted it and prepared for it. And oftentimes that brings them back. And then
I really like that. I really like that. You know, I'm just a very big fan of parts work, because I think that when we can say to a client like that, that there's a part of you that has the job of at some point sabotaging, and there's another part that I believe is very invested and wants to do this.
That opens it up and give them another possibility.
That's it. And that helps to depathologize as well. Yeah.
Beautiful. Well, Lisa, that went by so quickly. I'm feeling badly that we can't do more, but that's why we have part twos, by the way.
Okay, okay.
So I hope you'll promise us a part two. I really, really want to thank you.
It was
for-
my pleasure, and I'm just very honored that so many people are on so late at night. That's
Yes,
incredible.
we had 100 people on here, at least 100 people, and that was amazing. And this is going to go out tomorrow morning or afternoon to about 925 or 950 people that we have. And you know, my gauge that I always say is how long you held the crowd. You had 90 people a minute ago. Now people are signing off. But if you were at 100 and you have 90 for an hour and a half almost, that's pretty impressive. So I found this to be immensely engaging. We're going to call it a night. And again, I appreciate it. For those of you who want to introduce yourself and